Welcome to the deep dive. Today we're jumping into something incredibly important, cerebrovascular accidents. You probably know them as strokes.
Right, a topic that touches so many lives.
Exactly. The brain is just, well, unbelievably complex, but also surprisingly vulnerable. Understanding strokes, what causes them, how to spot them, what to do, it's just crucial.
Absolutely crucial.
We've gone through a ton of research, your detailed notes, and our mission today is pretty clear. Unpack the causes, the types, the symptoms, and the really vital actions needed. We want you to leave feeling, genuinely clued in and maybe a bit more prepared.
And that preparation, that speed really of understanding and acting, it can make all the difference.
Hmm.
Knowing the specifics in a stroke situation can literally change someone's life. Could be anyone.
A loved one, a stranger, even yourself.
Exactly.
Yeah.
With stroke, they always say time is brain. Informed action is just everything.
Okay, so let's start right there. What exactly is a stroke? Fundamentally, what's going on?
Well, at its core, a CVA happens when the brain isn't getting enough oxygen. Simple as that. But the consequences are huge.
Like a power cut to a city.
That's a good analogy.
Mm.
Essential functions start shutting down. And when that oxygen supply is cut off, even briefly, brain cells start to die. That leads to permanent brain damage. It's an immediate, very serious crisis.
Permanent damage, that sounds final. Is it always severe?
It can be, but there's a spectrum, definitely. The underlying issue, though, is that lack of oxygen causing cell death. Now, the most common reason this happens, maybe 87% of the time, is a blood clot blocking an artery. That's called an ischemic stroke.
Okay, ischemic, a blockage.
Right. But there's another major cause, bleeding in the brain, a hemorrhagic stroke. That's different.
So clot or bleed, are there other factors?
Yeah, things can contribute, like narrowed blood vessels, arteriosclerosis, hardening of the arteries, or an aneurysm, where a weak spot in a vessel wall balloons out and bursts.
Got it. But the key takeaway is that immediate damage is happening. Urgency is paramount.
Absolutely. That permanent brain damage aspect really underscores why speed matters so much.
Okay, let's unpack those two main types you mentioned, ischemic versus hemorrhagic. And there's also this thing called a mini stroke.
Right, the TIA. Let's tackle them. So ischemic CVA, think of that like a blockage in a pipe. A clot forms or travels to the brain, lodges in an artery, and cuts off blood flow downstream. Low oxygen cell damage, that's the most common one.
Okay, blockage, makes sense. And hemorrhagic.
Hemorrhagic is different. A blood vessel actually bursts or leaks, so you get bleeding directly into or around the brain tissue.
And that causes problems because...
Because that blood increases the pressure inside your skull, what we call intracranial pressure, or ICP. Your skull's a closed box, essentially. Added fluid, added pressure. It can crush delicate brain tissue. Also very serious.
And the mini stroke, the TIA.
The transient ischemic attack. So a TIA is like a temporary blockage. The symptoms are stroke-like weakness, speech problems, but they resolve completely, usually within minutes or hours, leaving no permanent damage.
So no harm done.
Well, no permanent damage, crucially, but it's a massive warning sign. A TIA means you're at very high risk for a full-blown stroke soon. It's not something to ignore. It's a critical alert from your body.
So knowing the difference between ischemic and hemorrhagic isn't just academic?
Oh, absolutely not. It's vital for treatment. You treat a clot very differently than you treat a bleed. Giving the wrong treatment can be, well, catastrophic.
Like giving blood thinners for a bleed.
Exactly. That's why the first thing in the ER is usually figuring out which type it is. And it brings us back to that tip. Sudden symptoms, arm drifting down, face drooping on one side, sudden slurred speech, call 911 immediately. Don't wait.
Right. Don't wait and see. Okay, we know what happens during a stroke, but what about preventing it? Let's talk risk factors. Where does this vulnerability come from?
Good question. A lot of it comes down to things that damage our blood vessels or make clots more likely to form. And the number one culprit, hypertension, high blood pressure.
The silent killer, they call it.
It really is. Over time, that high pressure just batters the inside of your arteries, weakening them, making them prone to damage or blockage. It's the single biggest risk factor.
Okay, number one, high blood pressure. What else?
Smoking is a big one. It directly damages and scars blood vessels, makes them less flexible. Then there's high cholesterol hyperlipidemia. That narrows the vessels, like plaque building up in pipes.
Restricting flow.
Precisely. Uncontrolled diabetes is another major one. The high sugar levels make blood thicker, stickier, and damage vessel walls. And atrial fibrillation, or AFib.
That's an irregular heartbeat, right?
Exactly. That irregular rhythm can cause little clots to form in the heart, which can then break off and travel straight up to the brain. a common cause of ischemic stroke.
It's easy to hear these things, high blood pressure, cholesterol, and maybe tune them out a bit. But you're saying these aren't minor issues.
Not at all. Take blood pressure. If someone's consistently running, say, 142/94, that's not just a bit high. They are already at significant risk for a stroke.
So managing these isn't just about feeling better day to day, it's actively preventing a potential disaster.
That's exactly it. Taking your blood pressure medication regularly, if prescribed. That's not just managing a condition, it's stroke prevention. It's protecting your brain proactively.
Okay, so those are the risks. But if a stroke does happen, how can someone like me or anyone listening actually spot it quickly? You mentioned some signs?
Yes, and this is where the FAST acronym comes in. It's super important, really easy to remember, and incredibly effective.
Okay, break it down for us. FAST.
Right. F is for face. Ask the person to smile. Does one side of the face droop?
Okay, face droop. Got it. A.
A is for arms. Ask them to raise both arms. Does one arm drift downwards or feel weak?
Arm weakness or drift. Okay.
S. S is for speech. Ask them to repeat a simple sentence. Is their speech slurred? Are they unable to speak or hard to understand?
Speech difficulty. Makes sense. And T.
T is for time. Time to call 911 immediately if you see any of these signs. Don't delay. Every second counts.
FAST. Face, arms, speech, time. That seems really clear and actionable.
It is. And there's one more tricky clue, particularly relevant for hemorrhagic strokes. If someone suddenly complains of the worst headache of my life.
The worst headache?
Yeah, sudden, severe, often described that way. Especially if it comes with vomiting or double vision, we call that diplopia. That's a huge red flag for a bleed in the brain.
Yeah.
That also needs an immediate 911 call.
Wow. Okay. So fast and worst headache. Got it. Now, someone calls 911, they get to the hospital. What happens next? What are those first critical steps?
The absolute #1 priority is a CT scan, stat, immediately.
Why so fast with the CT?
Because it tells us if there's bleeding. Remember, we have to know if it's ischemic or hemorrhagic before we can treat it properly. The CT scan is the quickest way to see blood in the brain.
Okay, CT scan first. Then what?
Then in thorough neuroassessment, checking their movement, sensation, speech, level of consciousness, really gauging the neurological impact.
And then treatment. What about that clot-busting drug?
Right, TPA, or alteplase. It's a powerful thrombolytic, a clot buster. If it's an ischemic stroke, meaning no bleed on the CT, and if the patient gets to the hospital and can be treated within a very specific time window,
How specific?
usually within 4.5 hours of when the symptoms first started, it's a tight window.
4.5 hours. That's not long considering everything that needs to happen.
It's incredibly tight.
Yeah.
Delays in recognizing symptoms, getting to the hospital, it all eats into that window. That's why fast is so important. But the crucial point about TPA,
Yes.
it is only for ischemic strokes. It's an absolute contraindication, meaning you absolutely do not give it if it's a hemorrhagic stroke.
Because it would make the bleeding worse.
Catastrophically worse, life-threateningly worse. So that CT scan result is the gatekeeper for TPA. It's a critical life or death distinction.
That really drives home why identifying the type is so crucial. So TPA for ischemic within the window. What about other blood thinners like heparin or warfarin?
Good question. It's nuanced. For an ischemic stroke, if TPA is given, you generally hold off on other anticoagulants like heparin or warfarin right away. You don't want to add too much anti-clotting effect at once, increases bleeding risk. They might be started later once things are stable.
Okay. And for hemorrhagic, bleeding strokes.
The complete opposite. No TPA, obviously, and absolutely NO anticoagulants like heparin or warfarin. No antiplatelets like aspirin either. Nothing that promotes bleeding.
So what do you do for a hemorrhagic stroke then?
The focus is on managing blood pressure carefully, preventing complications. Seizure precautions are really important because seizures can happen after a bleed. And sometimes things like stool softeners are used.
Stool softeners, why?
To prevent straining during bowel movements. Straining, coughing hard, even sometimes sneezing vigorously, anything that spikes intracranial pressure. You want to avoid that with a hemorrhagic stroke as it could potentially worsen the bleed or rebleeding. Keep things calm.
Okay, avoid raising that internal pressure. Got it. Now, something I find fascinating is how a stroke affects people differently depending on which side of the brain is involved. Left versus right.
Yes, that's absolutely true. The two hemispheres of the brain have somewhat specialized functions. So a stroke on one side tends to cause a different pattern of problems than a stroke on the other.
Let's start with the left side. What typically happens with a left brain stroke?
Think L for logic and language. The left hemisphere is usually dominant for language abilities, speaking, understanding, reading, writing. So left brain strokes often cause aphasia, which is difficulty with language. They might also affect logic and sequencing tasks.
Okay, left equals language and logic. What about the right side?
Think R for reckless and prey. Really creative, maybe. The right hemisphere deals more with spatial awareness, recognizing faces, interpreting emotions, and judgment. So a right brain stroke often leads to problems like poor judgment, impulsivity, maybe neglecting one side of their body or space, left-sided neglect usually.
Impulsive behavior, that sounds challenging for families.
It can be. They might not recognize their limitations trying to get up when they can't walk safely. Understanding these potential behavioral changes based on the stroke location is really important for keeping the patient safe and for the family to cope.
Right, knowing what to expect. Okay, that leads perfectly into post-stroke care. What are the practical things families and caregivers need to focus on, especially around safety, like eating, moving around?
Huge areas. Let's start with eating and aspiration risk that's food or liquid going down the wrong pipe into the lungs.
Okay.
Big risk for pneumonia.
So what's the safest approach?
Initially, often NPO, nothing by mouth, until a formal swallow evaluation is done by a speech therapist. They assess the safety of swallowing.
And if swallowing is difficult, dysphagia.
Then often the diet is modified. Maybe pureed foods and definitely thickened liquids. Thin liquids like water are actually harder to control and more likely to be aspirated.
Thickened liquids. Okay, and how should they sit?
Eifeler's position, sitting up as straight as possible, 90 degrees if they can manage it, during meals and for a little while after. Also, tucking the chin slightly towards the chest when swallowing can help protect the airway. Flexing the neck forward.
Things to avoid.
Definitely avoid giving sedating medications right before meals, makes them sleepy, increases aspiration risk, and don't rush back to a regular diet if they have dysphagia. Follow the therapist's recommendations.
Makes sense. What about moving? Many stroke survivors have weakness on one side hemiparesis. How do you help them safely?
Falls are a huge risk. First, when dressing, always dress the weak or affected side first. It's just easier mechanically.
Reach side first. Okay.
And when helping them move, like from bed to chair, use a transfer belt or gait belt for a secure hold. Always transfer them towards their strong side. They can lead with their stronger leg and arm.
Transfer towards the strong side. Got it. What about that visual neglect you mentioned with right brain strokes?
Right. Hemi-neglect. They might ignore everything on their left side. You need to actively remind them and teach them to scan the room. Turn your head, look all the way to the left. Place important items like the call bell or their water within their field of vision. Initially, maybe more to their right, but encourage scanning.
And the impulsivity with right stroke patients.
That requires vigilance. Educating the family is key. They need to understand this isn't the person being difficult, it's an effect of the stroke. They need to anticipate potentially unsafe actions and set up the environment for safety, maybe alarms on the bed, keeping pathways clear.
Communication is another huge challenge. Aphasia, you mentioned it earlier. Can we talk a bit more about how to communicate effectively?
Absolutely. It's frustrating for everyone involved. There are two main types we often talk about, Broca's aphasia.
That was the trouble speaking, right? Expressive.
Exactly. They generally understand okay, but they struggle to get words out. Speech might be slow, halting, requires a lot of effort. The key here is patience. Give them time. Don't interrupt or finish their sentences for them, even if it's tempting. Let them try. Use simple questions, maybe yes, no.
Okay, patience for Broca's. What's the other type?
Wernicke's aphasia. This is trouble understanding language. Receptive aphasia. They might speak fluently, but the words might not make sense, like a word salad, and they have difficulty comprehending what's said to them.
That sounds even harder to navigate.
It can be. For Wernicke's, you need to use nonverbal cues more. Gestures, pictures, pointing. Keep your sentences short and simple. Use visual aids if possible. Again, patience is crucial. It's about finding what works for that individual.
Patience and adapting the strategy seems key. Okay, let's try to pull this all together. Can we walk through a couple of scenarios applying this knowledge, like prioritizing actions?
Sure. Let's say you encounter a client, clearly showing stroke symptoms, maybe that facial droop, and definite slurred speech. What's the absolute first priority?
Based on what you said. Get that CT scan. Immediately. To know if it's a bleed or a clot.
Exactly right.
Yeah.
CT scan stat.
Okay.
Another one, a client is found confused and they have hemiplegia paralysis on one side. What are your immediate nursing priorities?
Airway first, make sure they're breathing okay. Then check their neurological status. And blood pressure, you said that was critical.
Perfect. Airway, breathing, circulation are always key. So ensure the airway is open, then a rapid neuroassessment. Monitor vital signs closely, especially blood pressure, and get that CT ordered. See how it links together?
Yeah, it really does. The speed, the specific steps, knowing why you're doing them.
Precisely.
Okay, this has been incredibly informative. We've covered so much: the difference between ischemic and hemorrhagic, the big risk factors like hypertension, that vital FAST acronym, the absolute rule about TPA only for ischemic strokes.
The different effects of left versus right brain strokes, those crucial care strategies for things like swallowing and mobility.
And communication with aphasia. It's a lot, but it feels connected now.
It is all connected, and hopefully understanding these details empowers action.
So maybe a final thought for everyone listening.
Well, it raises an important question, doesn't it? Now that you have this deeper understanding, the symptoms, the types, the immediate actions, the different ways people are affected, how did that change your perspective? Maybe on how you'd react in an emergency, or even how you think about your own health or the health of people you care about. What might you notice now? What might you do differently, armed with this knowledge?
Something to definitely reflect on, that vigilance and knowledge could truly make a difference.
It really could. Keep asking questions. Stay informed.